Dr. Hugo de Waal. He's a consultant old age psychiatrist. He gained his MD at Free University of Amsterdam in 1989, following which he trained in the UK, becoming a consultant in Norfolk in 1998. He has published widely on educational topics in peer-reviewed journals, wrote 3 chapters, commissioned for international textbooks on psychiatric education and leadership.
Let's go back to what a diagnosis originally is, even if you trace its path through more than 2,000 years of so-called medical history. It is nothing else but a reflection of how humans organize the world around us. Our perceptions and experiences are multitudinous. And the only way to make sense out of the world around us, whether we are medics or not, it doesn't actually matter what we're talking about, is by categorization to some degree. So that's the starting point. It is nothing else but a normal human cognitive strategy to make sense of ourselves and the world. And we try to establish meaningful relationships between the things we perceive and think and feel. Because if I just leave it as it is, I wind up with a smorgasbord. You would wind up with a whole array of things that actually don't make much sense. You need to have relationships between those things. Whether they are actually reflecting a reality or not doesn't actually matter that much. Most of the relationships that we detect between phenomena that are of interest to us are either meaningful because that's what we were taught to believe, or we assume there might be an underlying association hitherto undetected, which will lead us to psychiatric syndromes in a minute, or we actually convinced that there is a causal relationship. Now, even if hard fact scientific relationships are described in that terms, it isn't actually unusual for that then to unravel as knowledge progresses, as the Higgs boson will soon illustrate. So these are core elements of the human's cognitive toolkit, and in actual fact what it does is it tries for us to gain as much control over a potentially hostile or indifferent world as we can. Now go to the discourse of health and illness, etc., etc. Le Riche, when things are expressed in thoughtful discourses, you will often find Frenchmen and French women crop up. In health, organs are silent, Le Riche said. He was a surgeon, by the way. No one who is healthy and is going about his or her daily business is seriously consciously aware of the kidney functions in its many ways, or how the liver is functioning, etc., etc. In actual fact, I once stated in this particular room here, in front of a slightly different audience, that if you would take my liver out and put it on the table, or any of yours, presuming none of us are alcoholics or whatever else, it would be very difficult to identify whose is whose. Livers seem very anonymous once they're out of the body. Not only that, they're also very silent until they start to malfunction. And that goes for most of what makes us up. In mental health, when you're mentally healthy, whatever that may mean, the one connotation on that is that reality is silent. You go about your own business without necessarily needing to question constantly and all the time what is what and why. It was very interesting to hear a young person, a young male who was recently diagnosed with schizophrenia, this is about 25 years ago, in an outpatient clinic, and one of the main problems that he was experiencing wasn't hallucinations, illusions, all that. The main problem was that he, when he was sitting down, needed to decide if he wanted to get up, which muscle would go first. So what his perception within his illness, whatever the diagnostic label was causing him to do was to lose let's say the trust that the body will do it automatically. He needed to consciously decide which bit goes first. The choreography became conscious rather than unconscious, and that's the way he described it. And that was the main problem he experienced actually. In mental illness, therefore, the reality around us or within us becomes loud. It declares itself. It wants attention, it wants guidance, it wants refutation, it wants all sorts of stuff that normally we don't notice that much. And it becomes to a degree therefore alien. This is not the world that is familiar to me. Quite intense existential emotions. So these cognitive processes, where we normally rely on, are first of all part potentially of the pathological processes if we decide those are there. But if the cognitive processes themselves are already suspicious, or suspect, and you can't trust them as a person within them, then you can't actually have any control whatsoever. So in that sense, mental illness can be thought of or understood as a phenomenon that makes you lose control over your world and yourself in it. That it's a bit charged, but that's the baseline to it. So you lose control in general, not completely. What I mean is that there is this flavour through all of those things, whether you're depressed or anxious or schizophrenic or dementing. It doesn't matter that much. All these phenomena, and Chris highlighted that within the statement that diagnostic labels actually don't say that much, because these are the central issues in all these illnesses. There's one, however, that doesn't sit in any diagnostic label properly, perhaps in anxiety disorders to a degree. The fear that you become overwhelmed, not necessarily that your life is at threat, or that might be there as well, but the constant report from patients in all sorts of disease categories, not just mental illness, is that there is this potentiality that you become overwhelmed by what's going on with you, which leads you to want to gain control one way or another, because that will give you a route out, perhaps. It might not, but that's what you hope for. If your toolkit is malfunctioning or is experienced as non-trustworthy, then you don't have very far to go. At the same time, Lariche pointed out, of course, that if you try to help someone with whatever system you deploy, in trying to find instruments with which you might regain control to some degree, and you call it a diagnosis, then it has to be realized from the start that what a diagnosis means to us is not the same thing for someone who has the illness, or the disorder, or the problem, or whatever else. And the silent gallstones are a diagnosis because we see risks attached to them, but they're silent, which means I don't care. Because many people live their lives freely and without sense that there are huge risks. One of the debates, of course, with statins and vascular risk factors. Why would you put yourself on a drug that causes severe flatulence in too many and impotence in many others, whereas there's not clear evidence that you are part of the statistical component of the congregation that might start to suffer from problems if you don't take them. So defining a diagnosis, if we go away from the methodological nightmare of American approaches in trying to categorize reality in something that is reflecting that reality, if we give up on that straight away, that is the 85-95% I completely agree with Chris on, defining a diagnosis does convey, silently, without being ostentatious about it, the promise that there might be a way to regain some control. And that's particularly important for ourselves, not as clinicians on one hand, because otherwise we won't be able to do much in our work, but for our patients and their relatives as well. If we have a diagnosis, however we construct it, all these things are constructs, then at least my experiences are understood in one way or another. Now, if that understanding is faulty, as it very often may well turn out to be 30, 40, 50 years later or longer, that is in itself irrelevant. The relevance of the semantics behind it lie not in its truthfulness, it lies in the fact that it gives me hope. It's as simple as that. The threat is taken away. So in that sense, a diagnosis is what they call a hermeneutical tool. It gives you that leverage upon yourself and reality that gets you to a position where you think, I can get on, I can start to work with this one way or another. And that's the feeling people don't have if you don't have a diagnosis. The level of existential insecurity and uncertainty that people have when they are quite unwell, but no one can quite make sense of it, and they go from one to another asking, well, what is the diagnosis? And, well, we're not quite sure what's wrong with you. People with ME will have suffered to a large degree of that in the past, and still do now. So formulating a diagnosis is nothing else but enabling a technological insight, which is a construct, to be incorporated into the activity of living. In that sense, it's the most powerful form of biofeedback that exists. Let's now go back to what Chris said, because I thought of this as well. In my own world of dementia care, the label dementia or the diagnosis dementia doesn't say anything at all. And even the subtypes don't tell you that much, except for the fact that the subtypes are probably wrong anyway. Southampton School will still say that vascular dementia doesn't exist. No, oh, sorry, I got that wrong. Alzheimer's disease doesn't exist because all Alzheimer's diseases are actually vascular, according to some insights. And others are, Institute of Psychiatry in London, completely the other side. Vascular dementia doesn't exist, it's all Alzheimer's. Of course, the truth of reality is that both are wrong and both are right. If we put not the diagnosis but the patient or the formulation, as Chris mentioned, that you could put that down there in the center, and that's where your starting point goes from. That's your starting point of designing or thinking, well, what are we going to do for you? Well, we've seen that with dementia care services because of the nature of that illness, if you can call it an illness, and the broad range of needs or problems that patients and their relatives experience leads to a service configuration that is slightly, well, it is certainly responsive. Now, I'll show you, this takes about 10 seconds because responding to a variety of clinical settings in which problems occur in one way or another leads to a particular way of designing a cohesive care pathway that tells you what sort of helpful intervention we can unleash upon you if you have a particular type of clinical problem. If you weren't demented when you started off, you will bloody well be demented by the time you're finished, because no one is able to make sense of that whatsoever. And this is not because we're doing it wrongly, it is because it is impossible. You cannot design a predictive, protocolaire pathway of care for people who have a wide range of different needs. It's exactly what Chris said. And in that sense, that activity stands in a proud tradition. For this is very old, probably 6,000 years old, and this is how it all started. Now, what is described here is it's a cursory mention in Genesis about naming things, and the fact that that task was given from God to the humans to do. What is happening here is that the only reason Adam is asked give the names to the beasts of the field and the plants, etc., it is because the assumption is that he, living in that world, is the most familiar with it and therefore can give the right names. But the idea that naming something is conveying a feeling of familiarity is the most important bit that we do in our context with patients. Because if you are ill and insecure, and you sit opposite someone who, for whatever system they will use, conveys that familiarity and says, well, I know, you've described what's wrong with you, and I know what it is. I've got a name for it, which is not because the name describes the actual pathological process, treatment interventions, and service configuration. No, the essence lies in the fact that I know what you've got is not something completely magical and mysterious. It conveys a feeling that we might be able to do something about it. And even in those very sad circumstances where someone says there's nothing much we can do for you, then of course a good physician says, and that's a starting point for us to start thinking how we can help you, rather than what you sometimes hear as horror stories where someone says, listen, you've got terminal cancer, there's nothing I can do for you, here's the number of, well, whatever. That's not medicine, that's callous, unhuman treatment. So that's why I think you shouldn't want to get rid of diagnoses. Not because there's so much wrong with it, because there is, but because there's so much good with it, because there is. There is absolutely no doubt about the fact that outside psychiatry, diagnoses are further, more robustly funded in something of a type of reality. And that is, of course, a direct, well, of course, my assumption is that it is simply because we're dealing with the most complex organ in the body, if not in the universe. It is a little bit easier to tease apart a kidney and see how it's functioning and what its roles are. And if you open up the skull and start dissecting a brain, there is pretty little structurally there to start you off with. So we are very early on. We are in psychiatry or in brain disorders. We are at the stage where physical illnesses perhaps were 1,000 years ago, and as you mentioned, were understood as to be imbalances within the humoral the four humoral components. And we still hear some of our colleagues tell people that they've got a chemical imbalance in the brain, because there is no such thing as a recognizable balance of chemicals in the brain. There are very many interrelationships, too many for us to even beginning to understand, and that's what we're suffering from. Now, if that is a valid point, and we are actually within psychiatric diagnostic thinking of about 1,000 years behind where our colleagues are, that is A, not our fault, B is actually the bit why we're in it, because we are facing the most complex problem within human illness or human health that you can fathom. It'd be a little bit stupid to throw the diagnostic concept out as the baby with the bathwater, because you would have to start with nothing at all. And the fact that we now can have all sorts of advanced genetic understandings of physical illnesses, and assumed perhaps in psychiatry, by the way, as well, is of course on the back of the fact that there is that 2,000-year history of physical tossing about diagnoses that were completely erroneous and wrong. And that is not that long ago. People were still, hemicorporectomies were still done in the early 50s.
So that's a very good point about the complexity and inability to understand this complex organ. And I have here with us today is Linda from the Spiritual Crisis Network UK, who deals with people who have been labelled by different labels by psychiatrists. So perhaps, Linda, if you can tell us your view on this debate topic today.
I guess, just reflecting back on what you said, that being said, that the understanding of the brain and the mind and how it works is a long way to go. And that really tells me why we're then putting this map of diagnosis on top of that when it doesn't fit, because we don't know enough. And that, I think, maybe is the core of the problem.
Yeah.
And from an advocate of patient point of view, I guess, I think part of the problem, as you said, you listed the problems of diagnosis. And one of them is that actually it serves maybe the psychiatric medical system more than the patient. Because as a patient, feeling that lack of control because they're out of shared reality. And of course they want control, of course they want hope. And there's huge power and influence that a psychiatrist would have, or a GP would have in that situation, because that person is very lost. But using diagnosis as a way of giving them the hope, I think is very limited and actually can cause more fear, because essentially it's a judgment from one side to a very individual situation. As you described, talking about the mother with maybe attachment problems who just lost her mother and went into anxiety. There's possibly a cause and an effect there, a whole series of processes and events that leads to the issues that person's having. And to just sort of cover up with a label such as schizophrenia, as a lay person, to be labelled schizophrenia, you may think it gives them hope, but I would have thought that actually if you start researching schizophrenia, it could become very, very scary. And yet there's a huge range probably of what we call schizophrenic or psychotic or whatever. So I think it always, for me, it comes down to serving the individual as a person within a process, as opposed to a fixed state, a fixed moment in time, which can become a label of a death sentence, really, or a life of medication, etc., which can do more harm than good, as we know. And instead look at what actually helps that person, because maybe rather than a label helping the person, it could be things that are known, such as on the Spiritual Crisis Network website, grounding. So having a grounded routine, having established routines, eating balanced meals, having a little bit of social life to get a sense of shared reality again, having sleep, regular sleep patterns, going walk in nature. All those things we know will help actually anybody.
Well, this is
anybody at all.
Can I respond to that? Because what you're describing is seriously familiar, of course, particularly in the world of dementia. I'm not saying that the usage of the diagnostic label or tool or whatever is in itself and of itself the reassuring. But without it, you won't have much to go on other than what counts for all of us.
Right. Well,
and that's
half the people aren't doing what counts for all of us. That's we
yeah,
get
but
that established first. So yeah.
well, I can't design in my head, a health system that caters for everyone in an equal way because you're all the same.
Well,
What I'm heading for is that the diagnostic label that is scary if it's used in the wrong way. It is to do with how to deliver bad news, actually.
Sure,
And if it is delivered in a bad, yeah, it's like a knife. You can make a wonderful dish with it if you carve your meat up. You can kill someone with it. There are problems with the tool if it's used badly, and it is happening in medicine all too often that it is being used badly. Throwing the tool completely away, therefore, is not necessarily the answer, but it is a starting point in that sense, from where the discussion and the conversation with the patient takes, where it takes root, and it allows. I completely agree with Chris that all the things that you described with that person you described in your formulation, if you leave it at the categorized label, then it doesn't tell you anything. And mind you, the formulation is nothing else but an equally, although less obvious, reductionist approach to someone's personality. And when you describe low mood and social anxiety in that formulation, those two are actually diagnostic labels of themselves. It's not that there's anything wrong with it. Your formulation is actually a slightly more user-friendly approach, and it gives more information than just the diagnosis. Just the diagnosis is that blunt tool that is too sharp and is being wielded unjustly and with damage as a result. If it's a starting point to a conversation, what does this now mean to you? Then the diagnostic moment is something from where the person with the illness can say, I can start work on this now. All too often when someone is asked and invited, well, what are your problems practically, and let's see how we can help you with that. But there is no real diagnosis. People still, and I think totally understandable, come back constantly saying, yeah, but what is it that is causing this? Because that's a normal human cognitive approach to testing reality and to understanding it. So it is a necessary component, but it is by no means the end point. Because if it is the end point, we're actually practicing in human medicine. Except for one thing, that the Germanic phenomenological tradition had a very scientific background and goal in mind, and that was to try and delineate disorders and illnesses that were hitting people in a way that made it easier for professionals to think about how to help. That was the background to Jasper's attempt to describe reality, not just to leave it at description. And that's the problem if you throw diagnostic thinking in that sense out. You stop the first step of comparative research in its tracks, because it becomes completely impossible then to progress knowledge in a rational way, as has been happening in non-psychiatric fields in medicine. Every time any of us think that something is a problem, and is it part of the problem or part of the solution, that of course always is a cognitive choice in our own mindset rather than a reflection of the thing that's on the table. I keep going back to the fact, and as you mentioned earlier, it's a tool that in the right hand and with the right way of using it can be helpful. The fact that patients tell us diagnostic thinking is wrong, I'm not so sure about that. I think what we hear from patients all the time is you're not listening. And that is a complete valid critique. If diagnostic labeling or thinking is allowing lazy practitioners to stop listening, then that is not a good usage of what is otherwise a potentially essential tool. So we shouldn't train people to forget about diagnosis and just describe, because that will preserve the human in the patient. But what we should do is strike off any clinician who callously is treating patients and their loved ones under the guise of a diagnostic label in a cursory fashion.